You can begin now, Rhoda, sorry.
Yes. Hi, good morning, everybody. Welcome back again to our meeting with FED Partnership, the power of partnership in the light of the latest event of COVID-19 pandemic. We start another session today with very distinguished speakers. I guess the last few days has been very interesting for all of us. It opened the debate, it opened opportunities for partnership among so many of our friends around the world. Today, we will focus on what we can do, what we learned from the light of the latest event, what we can do, what we can change, how we can change the future in light of the COVID-19, how we can take the partnership ahead and move ahead with it. I'm happy to welcome our friends, Dr. Shams Saeed and Francis Omosowa, in our meeting today. As usual, there will be a presentation which is 10 minutes. There's a place for question and answer that I would love the participant to take on from there. So without further ado, let me welcome Dr. Shams Saeed, who's from the WHO Quality, and who will us today in this session. He will talk on how we must retain our focus on quality for universal health coverage. So, Dr. Shams, without due further delay, please come and share this session with us.
Yeah, thank you very much, Rhoda, and greetings to all colleagues. And it's always a real privilege to be with FET friends and colleagues, and also to be alongside the distinguished panel members this morning. So in the next 10 minutes, what I'll try to do is to share some thoughts on why and how we need to maintain our focus on quality of care in the partnership work that we're doing, and how we can retain this focus on universal health coverage, something that I know that is dear to many hearts and minds that are with us today. Next slide. This is something that you all know well, but we should just remember that pre-COVID, there was wisdom that we can't throw away. We need that wisdom to act today, post-COVID, and the global focus on quality of care and the response to the call for quality within the fabric of universal health coverage was articulated back in 2018 in these 3 global reports. And next slide. And if we look at the very simple words that our Director General placed within an editorial, it was a very clear point that he was making, that we cannot assume that quality is a given, and that it takes vision, planning, investment, compassion, meticulous execution, and rigorous monitoring from the national level to the smallest, remotest clinic. And it's that smallest, remotest clinic piece that particularly the partnership community is well placed to serve. Next slide. One of the things that we would like, can I have the next slide? Yes, excellent. So many of you are also strong advocates for the primary healthcare approach. And as WHO, we are strongly emphasizing the role of primary healthcare within our work. If you could just click, this is the primary healthcare operational framework, and it articulates a very clear systems-based approach and also articulates some key levers for action. One of those levers is systems for improving the quality of care. I'd encourage you all to take a look at this PHC operational framework, because it does touch on services, but it also touches on empowering people and communities, multi-sectoral policy and action. All of these factors need to be considered. And if you can just click, you can see that we are focusing in on the result of improving access, utilization, and quality. So with that in mind, next slide, if we can remember 5 things, and I'm just going to focus on 5 points in the next 5 minutes. So the first point to emphasize, and many of you are very familiar with the WHO technical resources on the subject, but the Twinning Partnerships for Improvement work does allow us an opportunity to remind ourselves at each point that most partnerships are about improvement. So remembering the I in the TPI approach, improvement, gives us an opportunity to drill down on the necessary action in those smallest, remotest clinics that Dr. Tedros was mentioning. And this threefold approach of strong partnerships, improvement, and spread, making sure that those partnership activities are seen within the light of national systems, is critical. And these have ramifications on issues such as workforce, on health management information systems. All of these are interrelated. And I always hesitate to speak too much about health workforce issues with Francis with us, but these are issues that are fundamental to our work. Next slide. Second point is, while we're working in partnership, we need to think about planning for quality. This resource, the WHO Quality Health Services, a planning guide, gives us the overall rubric to plan for quality and reminding ourselves of the operational framework, the systems for improving quality at national level, at district level, and at facility level. The point of emphasis here that I might want to make is, let's not forget the role of the district when we're working on quality of care issues. So when we're working in partnership, and perhaps working in partnership at the facility level, let's also consider whether there could be some partnerships that focus in on the district level or at the national level. But irrespective of where the partnership lies, let's think about that multi-level planning to enhance the impact of the partnership work that we're doing. Next slide. I'd like to also draw out our attention to a specific area where WHO has recently done some work: palliative care. So over the weekend, we released a new technical resource that focuses in on quality health services and palliative care. I'd encourage you to take a good look at this. It's a practical resource designed to facilitate action on quality palliative care, again, from the national level to the point of care. I know that many partnerships are working on palliative care, and it's an area that warrants even further attention, that we could think further about as we move our needle on partnership work that enhances quality health services. Just to remind ourselves, in the universal health coverage thinking, we're always emphasizing promotion to palliation. So this is an opportunity for us to remind ourselves that it's not just about curative services, but it's also thinking all the way through the continuum from promotion to palliation. So thinking about palliative care is important from all aspects, but particularly from a human aspect. Should also emphasize that this resource that I'm just highlighting, it builds on existing WHO resources, including a new report on indicators to assess palliative care development worldwide, and the link is provided there. We won't have time to share the WHO video on the subject, but this I would really encourage colleagues to take a look at. It's a moving testament to the importance of palliative care. Next slide. The fourth point, and this is something that I know that many of you will have considered and thought very carefully about, is how is quality considered while maintaining essential health services during COVID-19. Our colleagues at THET have been heavily involved in the COVID-19 Health Services Learning Hub that WHO has launched. And there is clear linkage point on partnership work, making sure that the wisdom of partnership work is informing the global pool of knowledge on how to consider quality in maintaining essential health services during COVID-19. We have a mechanism to capture lessons and wisdom from the field, action briefs and learning briefs. And in this learning brief, which I would also encourage you to take a look at, we examine quality considerations in maintaining essential health services and the importance of keeping an intentional focus on quality within national and subnational processes to successfully maintain essential health services. It is something that requires our attention not only today, but as we emerge hopefully in the next period from the COVID-19 situation, we should be thinking about recovery and how that affects our work in health services as a whole. Next slide, please. And finally, the fifth point that I'd like to emphasize today is critical importance. If I could have the next slide.
Rhoda, I believe we may have lost Dr. Saeed currently due to internet issues. So it may be that we might have to come back to Saeed, and perhaps we could go to Dr. Diane Ishiro or if she's able to join.
Yeah. Thank you. You lost me momentarily. It's one of those internet issues.
Check whether we've been able to reconnect.
Without due delay, we welcome Dr. Diane Ishiro, who is the Global AMR lead for Commonwealth Pharmacists Association and the lead pharmacist for the Antimicrobial Resistant and Healthcare Associated Infectious Diseases, Public Health in England, and antimicrobial pharmacist by background. She has co-chaired several multi-professional groups on antimicrobial stewardship outside of her roles as a primary health care. Diane is one of the editorial board of the public health journals, an oral lecturer at USL School of Pharmacy and more. So let's welcome her. Thank you for joining us, Diane.
Thank you very much. Can I just check that we can see my...
Yeah. Are we having Dr. Shams again? Hello? Yeah,
Rhoda?
please, Dr. Yes.
My apologies. I don't know what happened there, but there was a connectivity issue. Just to say,
I know.
Just to say thank you to everybody. The fifth and final point was related to compassion, and the plea there is to remind ourselves that we need to focus on compassion at every point that we work on. Compassion required at every level, from point of care to the global. So in the interest of time, I'll close there and thank you again.
Thank you very much, Dr. Shams. Thank you. Dr. Diane, welcome again. Please join us.
Thank you. I'll just share my screen.
Yeah, thanks.
Thank you. If colleagues can just confirm they can hear my see my screen, my presentation.
Yes. Yeah.
Thank you. Thank you. So good morning. Today I will be talking to you about antimicrobial resistance and the silent pandemic that could prove to be worse than what we are currently facing in this extraordinary times with the COVID-19 pandemic. In 2017, An AMR review study highlighted that each year, more than 700,000 people died from resistant infections, and that without action, that death toll could be as many as 10 million deaths every year by 2050. And this was compared to road traffic accidents and cancer deaths. And that this could cause 3.8% reduction in annual GDP. Also, that the world's poorest people and those living in low middle income countries are disproportionately vulnerable. In 2019, the World Health Organization declared antimicrobial resistance as one of the top 10 global health threats facing humanity. And as you can see on the slides there already, we have significant challenges with TB, as well as countries where they've reported treatment failures to last resort antibiotics. If you just hang on to that thought. What do I mean by antimicrobial resistance? This is when microorganisms change or mutate over time to a point where the medicines previously used to treat them are no longer effective for them. These medicines include antibiotics used to treat or prevent infections caused by bacteria, such as cellulitis, tuberculosis, sexually transmitted infections, such as gonorrhea, antivirals used to treat or prevent infections, such as viruses, such as HIV, antifungals used to treat infections caused by fungi, antiparasitics used to prevent or treat infections caused by parasites, such as malaria or threadworm. Pre-COVID-19 pandemic, although there had already been significant challenges with resistant infections, it was really difficult for the general public and non-specialist healthcare professionals to truly understand the consequences of having infections for which there were no treatments. Sadly, COVID-19 has brought the reality of what life without effective treatment for an infection could be. Thankfully, after a few months, vaccination alongside stringent infection prevention and control practices have made a significant difference alongside effective non-antimicrobials. Very aware that there are currently trials for antivirals. So globally though, since 2020, 6th of January 2020, and looking at the WHO website, there have been 4,843,000 deaths approximately as of yesterday at 5:52. I've recently found out from a study that actually recalculating the number of deaths attributable and associated with resistant infections, there are actually more than 3 million deaths in 1 year. We know that the background challenges to infections and those resistant to treatments have been there for a while. But what we are finding now is that COVID-19 is exacerbating antimicrobial resistance. A rapid review that was done in meta-analysis highlighted that despite the fact that there are low association of bacterial infections with COVID-19 diagnosis, so just about 6.9%, approximately 3/4 of patients with COVID-19, 70% approximately, were given antibiotic prescriptions. In addition to that, we know that in some countries, members of the public continue to purchase antibiotics to treat or prevent COVID-like symptoms. These actions further promote the development of antimicrobial resistance and could in fact worsen resistant infections as a result of the pandemic. We know that overuse of antibiotics in humans with ongoing uses in animal health, alongside the dearth of antimicrobials in development pipeline, causes significant challenges. And as we all know as healthcare professionals, even if we have a new class of antimicrobials developed today, and we know that we've not had a true new class in 30 years, if we do not use those antimicrobials prudently, resistance will very quickly develop. Unfortunately, competing priorities to deal with the pandemic, as we would expect, has led to reduced focus on strategies to tackle antimicrobial resistance within many organizations. Having said that, there have been pockets of continued focus, and we have been particularly in awe of several of our health partnerships that were part of the Commonwealth Partnerships for Antimicrobial Stewardship, and I know that our colleague Dr. Dodo presented yesterday. who at the very initial stages pivoted support, which was focused on antimicrobial resistance during 2018-2019, and very quickly pivoted to support each other through the COVID-19 crisis, including, for example, the very well-timed delivery of hand washing facilities in Uganda for community health workers, and the scaling of training of producing local alcohol hand job by the CW PAMS partnership in the Brighton-Lusaka partnership, which is in Zambia, from one hospital to several more hospitals in Zambia. And then sponsorship by the Commonwealth Secretariat to make it possible for us as CPA and alongside working with colleagues at TEF to make that possible, to make that training available online. This particular initiative, which started off during CW PAMS, also led to significant bidirectional learning for colleagues in the UK when UK became a resource limited setting in the fact that we had no alcohol, we had scarcity of alcohol hand job in the country. And colleagues in Brighton at the university and hospital were able to use their learning, which they gained whilst they were in Zambia, to produce alcohol locally within the hospitals. And you can see that in the photos. We also know that our first set of 16 global health pharmacy fellows who supported the partnerships found that participating in the partnership and traveling to countries and meeting colleagues in the 4 African countries, and I'll talk a little bit more about that shortly, really helped to increase their levels of resilience and increase their frugal innovation approaches throughout the pandemic, which still continues. So what is the Commonwealth Partnerships for Antimicrobial Stewardship? For the last 3 years, TEF and Commonwealth Pharmacists Association, which I'm part of, a charity which has a mission to support pharmacy professionals across the 52 Commonwealth countries, have worked together in a true partnership approach to lead the CW PAMS program, which is funded by the UK Aid Fleming Fund. We have supported 12 health partnerships, connected 187 healthcare workers. Just going to move my slide along. Connected 187 multidisciplinary healthcare workers and academics in the UK with 102 colleagues in Ghana, Uganda, Tanzania, and Zambia. And they collaboratively developed antimicrobial stewardship and infection prevention and control interventions, as well as built training capacity to help tackle antimicrobial resistance. Staff across the 5 countries, so UK and the 4 African countries, volunteered their time and expertise to develop these projects and interventions. And this resulted in over 3,000 healthcare workers being trained in antimicrobial stewardship in the 4 countries, and more than 250 of them were pharmacists. In addition, as I highlighted, the first 16 Global Health Fellowship completed their leadership year. We also had great success with surveillance, and we went from one hospital participating in the Global Point Prevalence Survey. This was before the WHO Point Prevalence Survey was available, and this has increased to more than 10 through the Global Point Prevalence Survey, which allows individual institutions to collect their own data and to develop interventions. As I already highlighted, during the COVID-19 pandemic, CW PAMS both prepared and continued to support partnerships from healthcare institutions and healthcare workers in their infection prevention and control and antimicrobial stewardship partnership processes. And the partnerships were able to pivot work to include initiatives such as the alcohol hand job, which I talked about earlier. We know that the same and similar antimicrobial medicines, which are used to treat infections and infectious diseases, are used both in humans and animals and in animal health. Also, the resistant bacteria arising in humans, animals, or the environment may spread from one to another and across geographical borders. Addressing the rising threats to antimicrobial resistance therefore requires us to continue to have that global, holistic, and multi-sectoral approach, which we often refer to as One Health. In addition, we're really pleased that we've been able to extend the CW PAMS program with thanks to funding from the Fleming Fund to 4 additional countries. And on Thursday, we're very much looking forward to meeting colleagues from the UK, as well as the 8 African countries, now to include Nigeria, Malawi, Sierra Leone, and Kenya, in addition to the previous 4, at our inception events, which will take place on Thursday. And this will, so many of the partnerships we had from the previous, from 2018 are continuing, and we're meeting new partnerships. Together and in solidarity, we can continue to work together to prevent and tackle the patient safety, public and global health challenge of antimicrobial resistance. Thank you.
Rhoda, I'm sorry, you're on mute.
Thank you very much, Dr. Diane. That was very interesting, specifically talking about antimicrobial stewardship and the resistant, multi-drug resistant, which is very common in so many developing countries. Please feel free to have any question for Dr. Diane or Dr. Shams in the Q&A section, and we will try to answer it. We will move ahead with our presentation now, and I'm not sure if Dr. Haq is there.
Yes, I'm here now.
Oh, perfect. Thank you. Welcome, Dr. Haq. Professor Suleiman Haq. I'm welcoming now Professor Suleiman Haq is the Director of International Center for Climate Change and Development. The professor at the Independent University of Bangladesh, as well as Associate of International Institute of Environment and Development in the United Kingdom. He's the chair of Expert of Advisory Group for the Climate Vulnerable Forum, and also the senior advisor and locally led adaptation with Global Care, Global Center and Adaptation, headquartered in the Netherlands. Dr. Haq will take us through the contribution of health workers have to make in response to the climate crisis. So welcome, Dr. Haq.
Thank you. Thank you very much for inviting me and giving me this opportunity. Let me start by giving a caveat. I do not belong to the public health community. I'm a climate scientist working on climate change, but I believe that there are very many similarities and synergies to be had between the two communities going forward. And I will share some thoughts on how we can develop those. So my first observation will be to, well, let me start before I even give my observation with a little bit of background about myself. As you heard, I'm the director of the International Center for Climate Change and Development at the Independent University, Bangladesh, in Dhaka, Bangladesh, where I'm based. And for the last 2.5 decades, I've been working on climate change impacts on the most vulnerable communities in the most vulnerable countries in Asia and Africa in particular, a group of least developed countries, 48 of them, mostly in sub-Saharan Africa, but also in Asia, including my country, Bangladesh. And trying to identify the most vulnerable communities, work with them, enable them to prepare themselves to be ready for the impacts of climate change, which are going to be first and foremost affecting them, and it's already happening now. So it's no longer something that will happen in the future, but something that is already happening. And so the issue is now of emergency or crisis proportions, and no longer something that is to be anticipated and planned for anymore. Planning is now has to be implemented, and so the few observations, the three major observations I want to share with you on particularly the public health workers, particularly those of you who've been involved in the COVID-19 pandemic and crisis, is that the victims, the primary victims of both the public health crisis of climate COVID-19 and even the economic lockdown and other economic impacts of dealing with the public health crisis have both disproportionately hit the most vulnerable communities in every country, whether they be a rich country or a poor country. The people who got hit, the people who died were mostly poor people, sometimes people of color. In cities, it was the slum dwellers, people living in very bad conditions who were the most badly affected. And this was a true in all countries, whether a country is rich or a country is poor. The most badly affected are the poorest and most vulnerable people. This is absolutely the same as climate change. In fact, as I said, for the last 20 years, I've been working with these vulnerable communities who are vulnerable to climate change. And when the COVID crisis occurred, they also turned out to be the most vulnerable to the COVID pandemic, both the health crisis as well as the economic one. And I've been working with them on how we can build their capacities and their resilience, both to the public health problems as well as to the potential climate change problems, which are not potential anymore. They are happening. Climate extremes like floods and cyclones and hurricanes and heat waves are now happening everywhere, and they will continue to happen. So it's no longer something that we have to plan for. It's something that we have to implement and react to immediately. So a big lesson is that the most vulnerable in any society are the most vulnerable to both public health and climate change, and therefore they should be prioritized in any kind of intervention that we are planning to do. The most vulnerable should be our priority. Sometimes they are, sometimes they aren't. Unfortunately, a lot of the time they are not. So we need to be making sure that they are. The second observation and lesson I want to share with you is the evidence and scientific inputs that need to be taken into account in decision making. And again, the COVID-19 crisis, which is a global crisis, but it has been tackled at the national level by every different country's government separately and differently, has demonstrated that leaders of countries who relied on the science, listened to the scientists, took actions in accordance with the science, were able to relatively better protect their citizens against those leaders who did not listen to the science and did not believe in the science and did not take actions commensurate with the scientific evidence. And the biggest example of that is the richest country in the world, the United States of America, under previous President Trump, who denied the science and did not believe in the science. And that's equally true for both for the COVID-19 pandemic as well as for climate change. And so decision making, taking science into account, has to be a priority. And those of us who are in the scientific field need to be better advocates and better advisors to politicians and decision makers at the national level in the different countries that we operate in. So decision making that is science-based, evidence-based, has to be promoted, advocated for, and made more effective. And those of us who are on the science side of this equation have to be more effective in dealing with our own politicians and decision makers to make them understand the science and the consequences of what they have to do. And then my third and final observation is that if we think that the COVID-19 pandemic crisis, which we are still going through, has not ended, is a major global impact for everybody on the planet, we haven't seen anything yet. Climate change is coming at a pace that is going to knock out everything that we have seen with COVID-19. And we have to gear up. We have to get much, much better at doing what we do. Obviously, we have to continue doing what we do on the science side, but we also have to get better at communicating it with not just decision makers, but with the general public. Again, the general public have to be on board. They have to be better informed. They need to be the ones who understand the issue and therefore are taking actions and being willing to take the actions that are needed in the collective interest. So the final point I'll make is that a global problem like COVID and a global problem like climate change requires global solutions. We cannot have national solutions and think that we are going to protect our own people and not be able to put a wall around ourselves. It's a global problem, global solutions. Leaders have to act globally and together, and people have to act globally and together. So those of us who are in the scientific community need to be connecting with each other better, sharing our knowledge and experience with each other better, and hopefully being able to influence decisions at higher levels of decision making. And finally, as you may know, the climate change community is coming together with a big summit in Glasgow in a few days' time in Scotland, hosted by the UK, by Prime Minister Boris Johnson. So that is going to be an occasion for the world leaders to come together and come up with solutions to tackle climate change, which now will be informed by the COVID-19 pandemic outcome as well. And hopefully we will be able to learn lessons and take things forward in a positive direction going forward. But the final point is, it's everybody's responsibility. We cannot leave it to just leaders. We are going to have to take actions ourselves. So I'll end there. I'm not sure whether this was particularly helpful for you, but I hope it was useful for you nevertheless. Thank you very much.
Thank you, Professor Salabani. This was very useful, and it's not away from health, because the crisis which we have all over the world now is climate change. And this is the time, as you said, that we have to take serious action collectively for the better of the rest of the world. Thank you so much. Please, again, feel free to have any question, and put any question in the question and answer section. Let me welcome Professor Francis Omasowa, who is the Executive Director of the African Center for Global and Social Transformation, which is a think tank in Kampala, Uganda. That think tank focuses on health system leadership and governance, health workforce, and strategic communication. He's the publisher of the Africa Health Journal, Chancellor of Soroti University in Uganda, and he also served as the founding Executive Director of the Global Health Workforce Alliance and Director General of Health Services in the Ministry of Health Uganda. Welcome, Francis Omasoma. Looking forward to hear from you the crisis expectation facing health workers in the International Year of the Health and Social Worker. Thank you.
Thank you, Rhoda, and good morning all. And maybe there are some who are already good afternoon, and the ones maybe Professor Hack's side of the world and so on. My topic is the crisis of expectations facing health workers in this International Year of the Health and Care Worker. And let me start by telling you what happened to me yesterday. A young doctor and was consulting me about his future. He has just finished his internship. He came 300 kilometers away to register with the Ugandan Medical and Dental Practitioners Council, and is looking for a job after his registration. He didn't get registered. He has to go back 300 kilometers away, and he doesn't know how soon he will get a job. And getting a job now for young doctors, so even young nurses here in Uganda, is not straightforward like it was when I first graduated. And that is not just the story of Uganda alone. That is a story in many countries. We had something like that about Sudan and Nigeria and so on. And then they will be thinking, this doctor, what is my future like? Where will I be in 10 years' time? Will I be in Uganda? Will I be in another country? So those are the anxieties facing health workers in most sub-Saharan African countries. But of course, in other parts of the world, I am aware that in Canada, a few years ago, there was a protest by the doctors in the incessant increase in their salaries. And they were saying, please stop increasing our salaries. This is enough. But the salaries in other parts of the world for health workers are not so good. So during this year of the health care worker, we would like to use this year to mobilize a climate of opinion which recognizes and puts into action mechanisms for ensuring that there is a health worker who is motivated, who is supported, and who has skills for every person in every village around the world. The fact that we cannot achieve universal health coverage without health workers needs to be recognized. This campaign is on, but I wish it was moving faster. So how can we move it faster? These are some suggestions. First, the history. We've come a long way. Since 18 years ago, there was a report called Joint Learning Initiative, which shone a torch on the global health workforce crisis, characterized by widespread shortages, maldistribution, poor working conditions. And we set up then the Global Health Workforce Alliance, which I was privileged to lead. And through that alliance, we mobilized the international community into having regular meetings. We had the first global forum on human resources for health, and now they take place every 4 years. And we have also declarations, the Kampala Declaration, an agenda for global action. We have a 2030 human resources strategy, and we have now a global health workforce network. So a partnership which is trying to take these things forward. And more than that, Ban Ki-moon, when he was Secretary General of the UN, he set up a high-level commission on health, employment, and economic growth, which underlined the key importance of the health sector in being a source of employment, mostly for women, but also being a source of GDP. The GDP of Germany, for example, was shown to be 30% around the health economy, manufacturing, marketing of pharmaceuticals, and so on and so on. So following that, we now have, just before that, in 2010, we adopted at the World Health Assembly the WHO code on the international recruitment of health workers. Because part of the shortages, part of the impact of the shortages was that there is migration, particularly from the south to the north, from the poor country to the rich countries. So after many years of quarreling between ministers of health at the assembly, it was agreed, why don't we create one single pool of health workers whom we share through a code. And the code is beautiful. It is got clauses which address the interests of receiving countries, sending countries, health workers themselves. And if this code is implemented as it is written up, it will be able to enable the world to solve this problem of shortage of health workers through the use of the code, bilateral agreements, multilateral agreements, training and capacity building. And following the Ban Ki-moon Commission, we also now have an international platform on health worker mobility between ILO, WHO, and so on. There are about five agencies here which have a compact on safe and regular migration. And so the stage is set for the code to be fully implemented on migration of health workers. And this code now is going through various updates and so on. But there isn't, in my assessment, enough interest, particularly in the richer countries, to promote and use this code as much as we would like to use it. But in order also for the code to be used well, we need to have global accreditation and quality assurance standards for trainees. If you come from Uganda, like this doctor who came to see me yesterday, are his qualifications recognized globally? Can we get a passport, a certificate, which has portable health workers? They can move from one country to another. I'm pleased to report that there is also work going on this. There is work between the World Federation of Medical Education and FEMA ECFMG to accredit institutions around the world on a regional basis, so that here in East Africa, for example, we have one body, in West Africa, in Asia and Western Pacific, and so on and so on. And it is those recognized by their own regional institutions who will be able, from 2024, will be allowed to take the ECFMG and the FEMA exams, and also the World Federation of Medical Education is in partnership with this group to ensure that we have a system which accredits and enables those with the right type of skills to go on the global market. And if, therefore, we are able to train these rich countries supporting the poorer ones who have a lot of young people, and we have that pool, and we have contracts which are made between countries to share nurses, laboratory technicians, doctors, and so on, then we have hope for each and every country to have the health workers which they need, and for each and every person in every village, everywhere, to have a skilled, motivated, and supported health worker. So those words, I'm quoting them from J.W. Lee, the late Director General of WHO, who in one of our meetings just blurted them out, say, what is the purpose of our work? And that is it, to provide for every person in every village a skilled, motivated, and supported health worker. That is our mission. Let's go for it. Thank you.
Hello, everyone. I'm Louise Mcgrath. I'm just jumping in. I think Rhoda's connection has failed her. I'm the Director of Programmes at THET. Thank you so much, Professor Omazwa. That was a very uplifting and insightful view of the challenges, but also some of the ways forward to address the challenges of the health workforce. Rhoda is back. Back to you, Rhoda. Thank you.
Yeah. Thank you so much. Sorry about that. My connection went off for a while. That was very informative session, I believe. And we have some question here that needs to be answered. The first question is directed, and we'll try to get back to all those before we leave. The first question is,
apologies again, everyone. I think we've lost Rhoda. She's obviously having a number of challenges with her internet. So let's look at some of the questions. If we pick up on the first question, which I think Rhoda was referring to. So that's a question for you, Diane. So have you started to see a change in practice in the countries you're engaging with at present with regard to antibiotic prescribing? And if so, when do you hope to extend your training even beyond the 4 countries you have mentioned?
Thank you very much.
Including to South Africa. Thank you.
Yes, we started to see changes in practice. So, for example, surveillance, that's a really powerful way of assessing level of prescribing and feeding that back to the prescribers. And that led to changes in guidelines. Obviously, what is really important with surveillance or with stewardship interventions is that you continue to monitor that. And we're really pleased that in some of the partnerships, they've been able to continue that ongoing monitoring and interventions and developing new interventions as a result of what they're finding out. So there is some movement, but with all, as you know, for you to embed and to have sustainability, it takes time. And so we are working with particularly the partnerships that are continuing. That's why we're really pleased that we're able to fund more partnerships to continue and to go further in trying to embed some of the learning that they had through the first round of CWPAMs. And I think the next question was, when are we expanding beyond 4? We have expanded beyond 4 as of tomorrow. We're going to have an inception event with 14 partnerships. Some of them are part of the previous partnerships and some of them are new. And we've extended to 4 countries. So we now have Ghana, Uganda, Tanzania, and Zambia as the original 4. And we are adding Nigeria, Kenya, Malawi, and I may need help. Malawi and there's one more that's just escaped my mind now, and I need your help, Louise.
Sorry, and I was reading the next question, so I haven't heard which ones you'd said. Sorry.
That's fine. I'm just going to get them up and say that. So it's so we've extended dates, and I'll put that into the chat now. So yes, we have extended, and what we are continuing to do, I'm not sure what part of Southern Africa you're from, but we can see if that's one of the countries that we are going into now. But yes, we have expanded as a result of the success from the previous set of funding that we had.
Thank you so much, Diane. And I hope one of the team is putting the countries in the list. And apologies that I was distracted with the next question, so couldn't help out there. So now a question for Professor Huck. Is Professor Huck still with us? Let me just check. No, he isn't. So we'll move on in that case. A question another question for you, Diane, if you're happy to take another point. So it's a question from someone in Uganda. The community pharmacies are second to hospitals in terms of the most dispensed antibiotics. Is there a plan by CPAMs to expand the interventions being implemented to community pharmacies?
Yes, there is the simple answer to that. And what we have done as we built the call for the current, for those who are starting their partnerships, is to ask, particularly for those who have been, who have had a long-standing partnership, so what we call the established partnerships, to expand beyond hospital, which was the original focus, into community pharmacies, also community health workers. And in fact, from the original 4 countries, a couple of the partnerships already focused on community health and community health workers, which will include community pharmacy. Thinking particularly of the LECMA and so the Ghana Public Health and Faculty of Public Health in England, their partnerships focused on LECMA Hospital, but also the community pharmacies around them. So yes, we are expanding to community pharmacies, and and I know that also there'll be more partnerships in Uganda who will have a specific focus on community pharmacy as well.
Thank you very much, Diane. And a question for you now, Shams. Thank you also for such a rich and insightful presentation. But do you have any advice for individual healthcare workers on improving quality of healthcare provision, either by their own actions or influencing system leaders? Thank you.
Yeah, thanks for that question, Louise. Yeah, just a few thoughts there. So first, to highlight that maybe taking small steps counts. So with any quality improvement journey, there are multiple steps that need to be taken at the facility level. And ensuring that there's a systematic process for that improvement cycle to take place is key. Demonstrating early success and candidly demonstrating or highlighting challenges and bottlenecks enhances I suppose the credibility of that improvement work at the facility level. And getting the partnership involved in improvement on both arms of the partnership makes a lot of sense, because that creates that solidarity, and I suppose that's the core principle within which partnerships work. But when that facility level improvement is taking place, keeping an eye on wider actions for quality at the different levels of the service and system is really important. And maybe the final point is making the case for quality is something that is required, and it's maybe it comes naturally to those perhaps involved in the partnership community, but making the case for action, not just on access to services, but making sure that the health workers that are providing the services are actually able to deliver quality of care, is something that I think warrants specific attention. And it warrants specific attention in many different settings. And this is where the adaptation required in settings of fragility, conflict, and vulnerability become quite important. And maybe just again emphasizing that within all of this, taking the lens of compassion makes a difference. And I think the partnership community particularly is well placed to really emphasize that role of compassion, and that how compassion can actually build that global solidarity around improving the quality of services for those that we serve. Louise.
Thank you very much, Sham. Some really rich responses there to a number of challenges that we want to make sure we can address. Now, I saw Rhoda pop back on, but I'm not sure whether she's stayed with us. So I shall continue with the next question for Professor Amazwa. We know that high-income countries are benefiting from inward migration of healthcare workers from lower middle-income countries. What would you like to see them do to strengthen those countries' health systems in return for that gain? And I think just picking up on that, you mentioned the interesting point that it's often challenging for health workers to find employment. So I suppose it's what are the issues affecting the finding of employment alongside the question raised there, if I may add that point. Thank you.
Yes, an excellent question. It is inevitable that there will be migration. And we from the South would like the richer countries to look at the code and take it more seriously and use the code through the existing institutions like the WHO and other regional bodies to plan with the southern countries on topics like improving education in terms of numbers and quality. Education and training is probably the single most important action that we can take to address the so-called global crisis. If we educate people with the right quality, and then we can share them inside our countries, and they will be available also for export. So investing in education systems in the southern countries is one recommendation that I would make to answer the question which is being asked. And then maybe number two, this doctor who came to see me yesterday, management systems for health workforce inside our countries is very unsatisfactory. Maybe also our partners in the North can help to strengthen the management systems inside ministries of health, inside countries, so that those who graduate here are able to get jobs and maybe then to move out without being as frustrated as most of them are. Thank you.
Thank you. And obviously some key issues there, but some great advice in terms of what we might be able to do as a health partnership and health workforce community to try and address some of those challenges. Thank you. There's another question here for Diane. So great work on antimicrobial stewardship in Africa. What challenges have you encountered in the current 4 countries you're operating in, and how have you succeeded in transforming mindsets? Thank you.
Thank you. So obviously in sharing the challenges, there are programmatic challenges, and then there are challenges that are faced by health partnerships. But very briefly, what we found was a good collaborative approach. So I have to say that in the first instance, amongst the healthcare workers as across both countries. But some of the challenges are linked to system challenges in terms of, for example, being able to access data and dispensing data to allow you to be able to develop the interventions. There are also challenges in which we were able to use, we had support from behavioral health psychologists to help develop interventions using behavior change strategies. So there were challenges in the context of perceptions and attitudes of healthcare workers, but very quickly through training, and not just training, because we know that training alone does not change behavior, but through training, through support, and through those interventions, those were able to be changed. There are some, obviously what we need to know is that there is a balance between access as well as excess. And when we're working in outside of high-income countries, we need to consider access as well. So there were challenges in trying to ensure that patients who arrive in the hospitals receive the adequate treatments. Often they may be more severely ill because of resistance patterns, or because of other arriving later for care. There were also challenges around linking microbiology data to use of microbiology data. So what I mean by that is that if a patient has a blood sample taken, they have their resistance pattern checked. Often that does not translate into changes in empirical treatment to allow for the next antibiotics to be used. We were able to support some of this, and there were also challenges around access to prescribing guidelines. And for that, we were able to develop an app which allowed healthcare workers and clinicians to be able to easily access their prescribing guidelines, the national standard treatment guidelines, in an easier format on their mobile phone. So we did some work around that. The challenge that then led to that was that sometimes patients are concerned if they see their healthcare professional on a mobile phone. But we were able to mitigate against, again, working with health psychologists, we were able to mitigate against that by having posters, for example, behind the healthcare worker to say, actually, by them looking at the guidelines, they are doing the best for the patient. I think the next question is, have you succeeded in transforming mindsets? I think that we've been able to do that for some colleagues, but it will be difficult to say we've done that extensively. The projects ran for the program started in 2019 at the beginning, and was meant to be an 18-month project or 15-month project, but COVID led to significant challenges towards the end, so there was an no-cost extension for partnerships. We will continue to work to support that and continue to use behavior change strategies where we can, because that's how we can help change mindsets. But even in the UK, where we have had stewardship for many, many years, I cannot stand here and say that we have transformed mindsets globally, totally in the whole of the country. Thank you.
Thank you, Dan. I think we're reaching the end of the session, but I think what's coming across for me for some of both the presentations and the responses you've all shared from the discussion is there are a number of issues, firstly around access, and UHC I think obviously has at its heart increasing access, but also to services and to antimicrobial treatment, etc., and to employment for that matter, but also the importance of data and science to inform what we're doing, and also to give us evidence to inform and help change the minds of decision makers. And I'm thinking also of the climate change piece, but also then strategies to change mindsets, to influence others, to bring about change. I think there are a number of themes cutting across all of the presentations you've shared that I think we can all try and see how we can adopt those in our own practice and in our wider communities. So thank you very much indeed, everyone. And I'm so sorry that Rhoda had challenges with her internet, as I know a number of us no doubt have had at different stages. But yes, really appreciated the insightful and very rich presentations and the contributions from the audience with your questions. So thank you, everyone.
Bye-bye.